Hello and welcome to the latest in our ESGE webinar series. My name is George Webster, and I'm absolutely delighted that so many of you have joined us, whether it's this evening or this morning, wherever you're logging in from around the world, for a really superb hour ahead to discuss how to become an outstanding colonoscopist. Now, this isn't just for the trainees and the fellows. This is really for anybody who delivers colonoscopy. And we've got two superb speakers, and there'll be great opportunities to answer questions after each talk. I would encourage everybody to use the chat box and send through your questions. We will do our very best to address those through the session. Delighted to be joined by my co-moderators, Professor Marianna Arvanitakis from Brussels, and Professor Siwan Thomas-Gibson from London. And without any further ado, I'm going to hand over to Siwan to introduce the first talk. Thanks, Siwan.
Thanks very much, George, and to ESGE for inviting me to join the webinar today. It gives me enormous pleasure to introduce our first speaker. Dr. Manmeet Matharoo is a consultant with me at St. Mark's in London, and I've had the pleasure of working with her for well over a decade. I've lost count after 10 years. And really, she's going to tell us about what we put into practice every day. As you've already said, this talk is for anyone of any experience. I've literally hot-footed it from a training list this afternoon, where all of the issues Manmeet is going to cover cropped up, including terminal ileal intubation. So Manmeet, with no further ado, if you get your slides up, we'd love to hear your tips and tricks on colonoscopy.
Thanks very much, Siwan, for that kind introduction. I hope you can see my screen. So I'm going to spend the next 15 minutes or so talking to you about tips and tricks for getting into the caecum. And just considering the overall title of this, How to be an Outstanding Colonoscopist, I think the key to being outstanding is getting the basics right. And basic intubation is something that we all struggle with. So I think it's important to revisit this. So just see if I can move my slides. So I have no conflicts. And I want to begin by saying that colonoscopy is a step-by-step progress. And the most important part of this webinar is David's talk, actually, polyp management. So that is the key. But to get good polyp management, you need to have really good time doing a good quality withdrawal. And to spend more time of your colonoscopy procedure in these last two boxes, you need to perfect your technique to have a really efficient, slick intubation so you can spend your time thinking about the more important aspects. So getting to the caecum, what is it that really makes it work? So set yourself up for a win. So as with everything in colonoscopy, it's all about the bowel prep. So make sure you spend time making sure the patient is well educated, because a clean colon is an easier colon to intubate. Making sure you've got adequate sedation preparation for this patient. So some of us will not all have access to propofol lists. So appropriate conscious sedation or an unsedated colonoscopy, but make sure your patient is set up appropriately for that. Use the adjuncts that you have. We use scope guide as standard in all of our lists, and actually that helps with intubation and loop management particularly. And the key, I think, for intubation is thinking about what are the cues? Have they had a previous procedure? Is there a report that you can access that gives you clues as to their colonic anatomy? Is it somebody that has a redundant, large, floppy, atonic colon, or actually do they have a very tight angulated sigmoid? Because that may well instruct the choice of scope that you might use. And also, I've said that intubation is really important about getting to the caecum, but think about planning your therapy. If you know you've got therapy to do, that's important. And part of that is actually defining what is the most important therapy. Are you going to worry about the small diminutive adenoma in the caecum if you know you've got a right-sided, a rectal lesion that's really important to deal with? So sometimes doing the retroflexion upfront helps you plan that therapy more carefully and appropriately. So I'm going to talk about three major points with regards to intubation. The first one, I think, is water insertion. Now, this is relatively new for some of us in our practice, but is a really important aspect to making your intubation easier and simpler. There's lots of evidence that now is there that it improves the time to the caecum. It's more comfortable for the patient. You avoid looping, and it has the added benefit of cleaning the bowel as you go along. And this obviously helps improve your adenoma detection rate. And this is really nicely illustrated by this graphic by Doug Rex, where you can see that whatever your colonic phenotype, even if you have that large floppy colon or even the tight angulated sigmoid, persisting with water really can help with your insertion. And if you get the sigmoid right, the rest of the colon tends to be less of a problem. But when you're doing a water insertion, beware, because you can miss pathology on insertion. Your views may not be very good. And if you've got poor bowel prep, you might decide that actually water insertion is not really right in this colon. I'm going to flip to using CO2 and flipping the patient's position. So the next thing I'm going to talk about is looping. So looping is something that we all encounter, we all worry about, and this is what can make or break your intubation. And I like to thank Siwan for this slide, because we all see loops in our life everywhere, even when we're not scoping. And we know that there's good ways of managing loops, and scope guide really helps with this. It's not just about what the scope feels like, it's what it looks like on the scope guide as well. So with regards to loops, don't fight the colon. If something feels like it's not happening, pull back. Try and keep a short, straight scope. And we've all been there where we've struggled with an intubation, and when our colleague or our trainer takes over, they always pull back and deflate the colon. So this concept of pulling back to inch forward, pulling back to inch forward, a bit like a caterpillar approach, is kind of really important to doing a sort of slow, careful intubation that's likely to be successful. Recognizing loops early with your scope guide or the feel or reading the colon ahead is important to managing them proactively. And I think trying to build in a systematic approach and algorithm to reducing those with pain neutral maneuvers first is important. And something that I was taught is that, you know, if something doesn't work once or twice, don't keep trying it a third time. Think of something new. So if position change hasn't helped and you've done that appropriately, then think about, should I try anterior abdominal pressure? So be systematic in your approach with loops. Position change. So position change is arguably still the oldest and the best trick in the book. And I think it's important to think about this in conjunction with what I've said about water intubation. So you would start in the left lateral with water intubation, but that may not work, and you may need to change the patient early in the sigmoid onto their back or even onto their right-hand side if you're struggling. But think about a hybrid technique. So many of us will use water insertion for the left colon, and when we get to the splenic flexure, turn the patient back onto their back and then go with CO2 insufflation. So you may need to adapt your approach and not be purist about only water or only CO2 to the caecum. And think about dynamic position change, particularly if you've got poor prep where water insufflation may be a bit more tricky. When you get to the caecum, it's really important to use position change to your advantage, because obviously we really don't want to miss pathology in the caecum. And, you know, supine, left lateral, or even right lateral is really good position to maximize your cecal views. So this is particularly important if your prep is not as good as you like, or you can't quite get the views that you want. Think about position change in the caecum. And importantly, if you are spotting pathology on the way in and you're making that mental roadmap of what you're going to do, make a mental note of what position was that polyp most accessible in, because that's important for your documentation if you're not going to do that therapy on that day. So documenting which position is good for accessing therapy is really important. And we've all been here, and we will all be here. What if you're struggling to get to the caecum? We've all had those days where you just have that nightmare intubation. So how do I approach this? Well, I think the first thing is to just stop and just check, is the patient still safe? Check in with your anaesthetist, check in with your nursing team, and just check that the patient is still tolerating the procedure. You're happy to proceed. And if you're not sure, I sometimes with an unsedated patient or a consciously sedated patient will just say, we're having a bit of difficulty, nothing bad is happening, but are you still happy for me to continue? You've reconsented the patient to make sure that they're still on board. If you're having problems, try and stop and diagnose, why is this intubation difficult? It usually falls into one of the three categories. Is it the anatomy of the patient? Is it that they've got really tight angulated sigmoid? Is there a stricture? Is there adhesions from previous diverticular disease? Or is it something to do with a floppy atonic colon and the PCF is just not advancing here? Or is it that you've got the wrong scope? Is it that actually I think I need a PCF and I've got an adult and I just don't have the flexibility to get around this sigmoid? And do I therefore need to pull out and change the scope? Or is it me? Am I just not doing what I need to do today, and do I need to get another pair of hands? Always revisit the indication, remind yourself, and I always share this in the checklist that the nursing team can prompt me as well. What is the indication? Is this an index colonoscopy for a diagnostic change in bowel habit? Or is it something that we're planning therapy from, a CTC, where we know we've got polyps on the right side? If, for example, it's a diagnostic case in a patient that's maybe elderly and comorbid and you can't get round for good reason, would a CTC be more appropriate and you back off and don't reach the caecum today? If you know you've got therapy to do, but you're struggling to reach the area, there may be a very good reason. So do you need to think of another approach, such as a double balloon colonoscopy? And if it's a tolerance issue and you haven't got adequate sedation, then do you need to rebook this patient on a propofol list, for example? And I like this idea of an endoscopic pause, which I know is kind of gaining traction, but I think needs to be built into your briefing and your team sort of approach, where if you're struggling, you can kind of just pause. And literally sometimes I just put the scope down and just have a look at the patient, check your ergonomics. Is there something with alignment that you need to correct? Is there a loop outside that you haven't corrected? And team situational awareness. So I'm very tuned into my nursing team. And if they're sort of twitching or worrying, then I know that that's a cue that the patient might not be happy or we need to do something different. But when you're entrenched in the procedure, you can have tunnel vision. You might forget to do this when you're concentrating really hard to resolve that loop or, progress. So just physically take a pause and just take stock. And don't make the AC look like the caecum. So if you're unsure that you're at the caecum and it's been a really challenging procedure, there might be a temptation to say, oh, this has got to be the appendiceal orifice, but beware, it might be right-sided divertically. And if you're persuading yourself to think that it's a caecum, it's probably not the caecum. So in which case, think about, do I need to just do a completion CTC because I may not have comfortably seen the caecum? And ask for help. We all struggle. That's why colonoscopy is different for all of us and every patient at each time. So think about asking for another pair of hands. And I like this quote. Somebody said this to me when I'm training: no one died because you didn't get to the caecum today. So although we all want to have high cecal intubation rates and we want to complete the procedure and we don't want to put the patient through another bowel prep, if there are warning signs that are telling you back off, it's not happening today, then back off. And what about when you're actually at the caecum? Well, this is the view we all like. This is our happy place. We got there. We're at the end. Hurrah, the procedure's finished. Well, no, this is where the procedure really starts. And this is where your cognitive drive kicks in, because this is where the withdrawal and the detection of pathology that David's going to go on to speak about is really important. So make sure you take your time in the caecum. It's really important to look at your landmarks, clearly photo document them. But don't get caught up in the action of photo documenting and forget to look behind the folds for those flat lesions. Come back from the caecum and take a long view and take a close-up view of the cecal pole as well. And don't neglect this area, because we know this is where we can often miss pathology, and we know about Lawyer's triangle. And to reduce our PCCR rates, we know that the caecum is a high-risk area, so spend your time looking in there. Don't just rush to get into TI and then rush to do your withdrawal. So I was told bubbles have no place in the colon. They're only for champagne and bubble baths. So think about making sure you use enough wash. So methicone wash won't be in your foot pump. So make sure you put enough bubble breaker in to get really good views. And I don't routinely do this in my practice, but I'm beginning to try and think about this as cecal retroflexion to make sure you see behind the folds and you don't miss those flat lesions. And I like this idea of sort of when you're in the caecum, you'll often inflate, so you'll get a good view, but actually deflating slightly might draw your eyes to any contours that might be slightly skew-whiff, which might draw your eye to a flat lesion. So be dynamic with your inflation and deflation of the caecum. And if you do see pathology in the caecum that you're not going to resect, really interrogate the proximity of the lesion to any landmarks. So it's really important when we have polyps referred to the polyp meeting for us to know, are they clear of the appendiceal orifice? What's the relationship to the valve? Is it clear of it? Because that's going to inform any future therapy. So terminal ileal intubation. So this is a good little teaching snippet for 10 minutes in between a scope change, which we did this week actually. So the key for TI intubation is, why do you need to do it? Is it essential? Well, yes, sometimes you need to do an IBD assessment. Sometimes it's to confirm that you're definitely at the caecum. But if you're really struggling, you might decide that actually I'm going to spend more time looking at the caecum. So what to do with regards to making your TI intubation successful? So I think the key here is to have direct visualization of your valve. And sometimes if you've got a hyperinflated caecum, what that does is it actually flattens the valve. So if you imagine that my hand is the caecum, and if I put a lot of air in, the cecal valve, which I'm demonstrating my hand here, this is the oral lip, and the anal lip might be actually firm tight if the caecum is hyperinflated. So suggest maybe deflating slightly, and that reduces the pressure on the valve slightly. So what I would suggest is you advance forward into the cecal pole, deflate slightly, pull back with your scope, find tip control, tip down, and at this point pause, and water insufflation actually really helps here rather than CO2, which just tightens up the angle. Water insufflation, gentle inward pressure, and then you have your TI. And you might need to practice doing this with endocuff because we're all now using adjuncts a bit more, but the same principles still apply. And I've got a little video here, courtesy of my colleagues from the Wolfson Library, just illustrating this. So here you see a nice cecal view. You can see the valve on the 5 to 7 o'clock border at the bottom. And at the top, there's just a cold snare polypectomy that you can see the defect. So what you can see is the endoscopist is filling with water here. So gone back into the cecal pole, put a bit of water in, deflate slightly, and you'll see as they begin to come back shortly, you see the oral lip of the valve, pause, water, gentle inward pressure, and there you have it, TI. So I think water over CO2 is helpful in this regard, but take your time, and you might need to use some fine tip left, right wheel to get into the TI to get the views that you want. So that's a good little mini teaching session that you can do with your fellows in between scope change. So in summary, to talk about cecal intubation and how to make it successful, set yourself up for a win. So that means think about all of the things that make your patient comfortable, prep, sedation, and make sure that you have the right scope. Think about water insertion and how you're going to incorporate that into your practice. Be proactive with loop management and use your scope guide and think about position change in an algorithmic fashion. Take your time in the caecum, because although that's where we need to get to and we need to think about withdrawal, we don't want to miss any cecal lesions. And if you're having a challenging intubation, which we all will have, diagnose the problem and try to be systematic with your maneuvers. Thank you very much. Here are some references, and I'm happy to take some questions.
Thanks so much, Manmeet. That was fabulous. Lots and lots of teaching in there. And we've got a couple of questions coming through, both from my co-panel, myself, and from the audience. And please, you can still type in your questions here and I'll ask them for you. So anyone else who's got a burning question for Manmeet, or any of us, in fact, please do type it into the Q&A. So Manmeet, one of the things that just coming off the back of that TI, and as I said to you at the beginning, we had 3 beautiful cecal intubations today by my trainee, but actually terminal ileal intubation was challenging for them in all of the cases. And I wonder what your feeling is about position, the best position for terminal ileal intubation. Do you have a favoured position? Do you bother changing position if you can't get in?
So I think whatever position gives you the best view of the ICV is what's important. So if you're on a supine position, I think that is quite good. As you can see in this video, the valve was positioned nicely in the 6 o'clock position. And I think I try to get the valve to 6 o'clock because I find it easier to tip down into the ICV. Whereas I know some people prefer to have the valve over at 9 o'clock, but then you're steering left, which I personally find a little bit more tricky. But I think the key is so long as you can see the valve and whatever brings you the best views. So if that's not working, you might want to change them onto their right lateral because you might find a better view that way. And I think deflating the caecum helps take the pressure off, and then you might actually get a better view of where the valve is.
Okay, so I'm going to go, because we've got lots of questions coming in from the audience. So we'll try and rattle through these. We've got about 10 minutes for questions, I think. So there's been a question, actually, David has answered one, but I think it's worth a brief discussion. And there's also been a question about use of PCF. So use of gastroscope, use of PCF. Are they in your armamentarium? And if so, when and how?
So really good point. Usually we run this through in our team briefing beforehand. So again, predicting what scopes you might need. So if you've got something, so a patient, for example, that might have had a previous difficult intubation, or an IBD patient that might have stricturing disease, you might have a gastroflexy on standby. PCF obviously would be useful if you know you've got a difficult tight angulated sigmoid, but if, for example, you were doing a surveillance procedure and you wanted high definition pictures, you might have to make that compromise. So it depends upon what scopes you have in your unit, what your list is looking like. And I sometimes reserve a backup scope to say, well, we'll start with this, but I might have a gastroflexy on standby if we can't get through. So it's usually a compromise between the quality of the visualization, the optical, the optics versus what the patient can tolerate. And it's kind of marrying those two things up. But that's where it all comes down to the indication. What is it we really need to answer in this clinical question, and therefore you work it out that way.
Yeah, I mean, for me, my choice will, unless, as you say, that they've had difficulty before, they've got adhesions, I don't choose a pediatric instrument. I mean, obviously there are all sorts of different brands of endoscopes, but certainly the ability to have enhanced imaging, if that's only with an adult scope, for me, particularly if it's an IBD patient or a polyp follow-up patient, I want to have that enhanced imaging that isn't on all of the pediatric instruments. And similarly, I do quite a lot of polyposis patients. A pediatric instrument won't allow you to suck up small polyps alongside a snare, whereas the bigger channel of an adult scope does. So if you're doing a lot of small polypectomies, you don't have to exchange. You can suck up and retrieve small polyps while the snare is still down. So these are sort of fine-tuning things, but exactly as you say, I think it's what's the indication. Okay, I'm going to rattle through. Do you add simethicone in addition to bowel prep? So you mentioned actually about bubble break or simethicone not being in the foot pump. When do you use it, and do you add it to the bowel prep?
So I don't have experience of adding it to the bowel prep. I think I don't think it's licensed to go in the foot pump, although some people have used it, but I think we're not officially allowed to do that. So we don't tend to put it in our foot pump, but we have it drawn up alongside. And I will always use it on withdrawal, I think. I will use the foot pump on insertion, but again, if there are bubbles that are hindering your view, that might interfere with your intubation, even with the water. So I would still use it. But I think it's really key when you get to the caecum to make sure that you use it then, because you'll probably have bubbles coming out from the terminal ileum and you'll have fluid coming through. So I would tend to use it on withdrawal where needed, but most definitely in the caecum.
Marianna, I think you wanted to come in on that. Did you want to comment on the use of simethicone?
No, I think that it's very important to have the clear view. So we use it a lot for the capsule, the video capsules, and I think it's also in the recommendation. So I think that we also use it as an add-on. There was another question about still where the ileum. So there's another question about using a biopsy forceps to help you get into the ileum as the Sellinger technique. I remember that they taught that to me 20 years ago. Is it still something that we still teach our trainees, or?
So I think you can. So sometimes you will have adjuncts on. So we often have like a transparent cap or maybe an endocuff. And so actually that gives you a little bit of purchase sometimes. But I think if you're going to be taking some biopsies anyway, if you're thinking about maybe IBD, you might use sort of the tip of the forceps just to sort of have a very gentle look down to see if you can work out where it is. I would slightly caution against trying to sort of use the biopsy forceps to lever in, because you don't know the anatomy they're on. And if there's stricturing disease, for example, that might be friable, you could theoretically cause a perforation. So I personally would sort of veer against that, but I would use water because I think it has a similar effect of providing purchase on that sort of lip to tuck you into the ICV. But I guess you can use biopsy forceps so long as it's under direct vision and cautiously, just to see that you can identify where you're going and then pull them back in and then go in with your scope. So having the biopsy forceps down, if you want to catch some TI biopsies and you've got an unstable position, might be a good idea. But obviously I would just caution, I would have the biopsy forceps back into the channel and then ready to go when you're in TI under direct vision.
Interestingly, I inadvertently benefited from that recently with a long colon with a pediatric instrument. And it was actually difficult to get the tip down to the caecum, one of those situations. And it was an IBD patient for surveillance, and we put the forceps down. I thought, well, I'm not going to be able to get into TI. We put the forceps down to start taking the biopsies, and actually that just stiffened the scope enough to allow me, I didn't have the forceps out of the end, sort of Seldinger style, but it stiffened the end of the scope enough to then allow me to drop down and into the ileocecal valve. My trainee thought I'd done it brilliantly and thought it was a deliberate teaching, which was, I took it, that's great. George, you had a question about the stiffener as we're talking about. I was
exactly that. Where do you think the role is for the stiffening facility on the colonoscope? Is it just another little toy that makes us feel better and then we convince ourselves that it's helped us get round? Or do we think there are specific moments in the procedure in which stiffening the scope is, should be part of our practice?
So I think it's an important point, actually, and I think I sort of use it in that algorithmic approach, as I say. So I would tend to think about it. It's really important with the stiffener thing. If you're going to use it for a really defined period, put it on, and if it's helped, then take it off again. I think the danger with the stiffener is that you might put it on and then forget to take it off, and actually that can cause problems further down the line. So be very deliberate about it if you are going to use it. And I think a good indication, and so I would tend to go for position change first, and then maybe anterior abdominal wall pressure, and then stiffener thereafter. So I try to use that. But I think a good example of where it does work is if you're in the mid-transverse and you kind of keep getting that mid-transverse dip. So I would pull back, deflate, anti-clockwise torque. And if that doesn't work, and I've tried anterior transverse lift, then I might pop the stiffener one just to get back over that kink in the transverse. And once I'm through over to the hepatic, then I'd take the stiffener off. So I think it has its place, as with everything. There's no wrong or right. There's no definite, you must do this, you mustn't do this. But I think you have to be considered in what you're doing and why and what it's going to achieve, and be really sort of clear in your own mind that if it hasn't worked and you've tried it properly, don't try it again.
Okay, thank you.
So we've got lots more questions, and I'll come to these. For those of you who haven't had your question answered, I'll do it while David's talking, and then you'll have the information after that. But there have been a couple of questions about looping and algorithms, which is too much to sort of cram into 1 minute. But Manmeet, what about having a loop and pushing through it, and use of abdominal pressure? Have you got a couple of comments about whether it's okay to push through a loop, and when do you use abdominal pressure?
So ideally, we don't want to push through with a loop for many reasons: patient comfort, patient safety, but also if you're planning to do therapy, you then don't have the tip control to do that. So you might get round, but then if you've got really big therapy to do and you've got a big loop, you can't do it. So, you have to think about, what am I achieving to push through? Is this just a diagnostic, or am I going to actually be able to do what I need to do at the other end? So we try to avoid loops, but sometimes actually people, if they've got a long mesentery and it's not angulated, they can tolerate loops. So your patient might be quite comfortable. Your scope guide is giving you the heebie-jeebies, but actually you might decide that actually I can cautiously go through here. I think you have to really read the patient, read the colon and read the scope guide, and try to pull back. And if you've tried all those algorithms and the patient's comfortable, and you might be able to progress through. Some loops are tolerated and the patient is okay. So I wouldn't again say you never do it, but I would try with all of those algorithms that we've described in some of the references to try and manage that. And you can use anterior abdominal wall pressure with regards to loops. Another thing is sometimes you really struggle, particularly maybe with a patient that has central adiposity, to get really good targeted pressure. And the thing with pressure is it has to be targeted. So using the probe on the scope guide to really find out on the scope guide, where is this pressure? Because what you might think is sigmoid pressure actually is deep pelvic pressure. So you need to think about targeting that pressure. Another tip is the assistant that is putting the pressure on, make sure that the bed is their height so they can actually do the pressure properly. And the last point is sometimes prone position is really good if you can't get effective abdominal pressure. So think about those things.
Okay, lots of information there. There are a few questions which I'll answer about where can people read more about this. You've given some great references. I'll answer those in the chat. And just to say before we move on, the last question is fantastic, which is to say, please document in your endoscopy report the difficulties you've had and what worked. So cecal intubation, best in the prone position. I love those endoscopists who are helpful. So I'm going to wrap up there, and I think I'm going to hand over to Marianna now to introduce our next speaker. Thanks very much for a fantastic talk, Manmeet.
So thank you very much for this this talk and the discussion. So we're going to go on now. We've done our colonoscopy, so we have to detect and characterize our lesions. So I'm very happy to introduce the next speaker, which is David Tate from UZ Ghent, who has not only done an amazing amount of research on this subject, but also has a very good educational platform on the subject. So I'm sure that he's going to throw some light on this subject. So Dave, the screen is yours.
Thank you so much, Marianna, and thank you so much to you and the ESGE for the opportunity. Do you see my slides, Marianna?
Yes.
Okay, perfect. Thank you. All right, so I want to talk in 15 minutes about lesion detection and characterization in colonoscopy. I want to give you a rationale for the importance of endoscopic imaging to discriminate predominantly cancer in colorectal polyps. I want to try and simplify this problem a little bit because we understand that it's complicated and there are hundreds and thousands of classification systems out there, all of which are a little bit difficult to understand. And then I want to give you a structure to look at any polyp and decide whether or not it contains cancer. So are we good at this? We are not good at this. And these are the most published studies which show the accuracy of endoscopists who have undergone training in determining whether there is cancer in a colon polyp. So maximum 40%, and in probably real world practice, it's maybe about 30%. Why are we getting it wrong? Well, maybe we're thinking about, oh, is this a tubular adenoma? Is it a tubular villus adenoma? Or not, is it cancer or not? Maybe the systems we're using are too complicated. Maybe no one's really given us a system in our education to look at a polyp and understand why or whether or not it's cancer. And here you see lots of classification systems. We want to avoid this, and I'll try and avoid them in our talk. People have thought about algorithms, but the problem with these algorithms has really been that they're not particularly applicable to non-experts. And if they are, they still focus on these very difficult and very complex classification systems that nobody who isn't doing endoscopy all the time has time to pick up and learn. So consider these images. So this is a polyp. This is zoomed in on it. This is another one, zoomed in on it. This is another one, zoomed in on it. And I think you can probably appreciate that in all of them, there's a little bit of extra redness, maybe a little bit of extra redness here and here that draws your eye. And then you go in closer and you focus on that area. And this was a concept popularized by a guy called Malcolm Gladwell in 2005, who had this idea that blink thinking, so thinking without thinking is how he called it, is a way that the brain makes very rapid decisions. And maybe it's an idea that we like, but is it true and does it work? Well, what is it in colon polyps? It's this idea that we look very quickly at this image and our eye is drawn to this central area. So my blink impression of this positive, my first impression of this polyp is positive for cancer. Why? Well, folds are coming into the center of this. It's maybe red in the center and there's a depression here. We know from lots of study into blink response that is highly dependent on your experience. So if you've seen 100,000 polyps, you make good blink decisions. If you've seen no polyps, your blink decision-making is a little bit more difficult. So in this case, potentially someone might make an incorrect positive blink assessment of this polyp because it's quite big. They maybe never seen anything like it before. Maybe they think, my God, that's so big, that must be cancer. And this was a tubular villus adenoma with low-grade dysplasia. So it's a good concept. It's a positive concept, but it's also possibly a dangerous concept because patients may end up getting sent for surgery when they don't need to, because people think things are cancer when they're not, because they are not experienced at blink decision-making. So we always recommend in all of these algorithms that the next step after your decision-making, if you're not an expert, is discussing in a multidisciplinary environment. Just to let you know, there is some evidence supporting this blink decision-making now. We defined 6 key blink features. They are fold to deformation, extra redness in the polyp, chicken skin mucosa around the outside, depression in the center, spontaneous bleeding, and ulceration. And we showed that if you have no cancer in a polyp, you have a mean of 1.1 of these features. If you have superficial cancer in a polyp, the mean was 2. And if you have deep, the mean was 2.3. And these were statistically significant differences. And the only training that people had to do this, because they were endoscopists of all sorts of experience, was a 2-minute learning intervention explaining those 6 features you saw on the previous slide. So maybe blink decision-making can be an important concept in colon polyps. But for the inexperienced, it's very important to blink first and then take a closer look. So what is taking a closer look? Well, the first thing to look for is a demarcated area. So that is an area within a polyp which looks different to the surrounding. Here is one, here is one, here is one. And you want to look carefully at that area using the virtual chroma endoscopy, MBI, eye scan, whatever that it is on your scope system function of your endoscope. Now, you will be familiar probably with the NICE classification. So this is NICE 1, lighter than the background. NICE 2, darker than the background. NICE 3, darker than the background. But maybe you're not familiar with the JNET classification. Now, if we just look at this JNET classification, it's very imposing. It was brought up by the Japanese. It tends to be misunderstood. But essentially what they did was they split the NICE 2 structures into 2. So you had NICE 1 was still NICE 1, and JNET 1 is NICE 1, and JNET 3 is NICE 3. But the 2 was split into 2. And why was it? Well, because there are things that are regular, which are benign, and there are also things which are starting to become irregular, but are not completely irregular, which are also benign. And this nicely defines what you do with the polyp. So remember, we're talking about that demarcated area within a polyp, and then we can describe it in these terms. Take JNET away. You don't need the word JNET. You just need to know if it's regular, irregular with some structure, or completely irregular. And that nicely determines what it is in terms of a polyp. Maybe here a serrated or hyperplastic polyp, here an adenoma, here maybe getting on for high-grade dysplasia or early cancer, and here deeply invasive cancer if there's no structure. It defines the cancer risk very nicely, and it means that really you don't need to understand NICE or JNET. You just need to describe the structure of any demarcated area as regular, regularly irregular, or irregular with some structure, or irregular. And it makes the whole thing a lot easier. So consider this polyp. This polyp has a demarcated area within it. If both of the demarcated area and the polyp are regular, there's looking like this, then you have something that looks like this. So you have a clear demarcation area in this polyp, demarcated area, but the outside is regular and the inside is regular. And so this is a demarcated area, but not a true demarcated area. It is what is commonly known as a valley sign or a pseudo demarcated area. And this polyp was a tubuloadenoma with low-grade dysplasia. What about the more concerning ones? Well, those are the ones with irregular demarcated areas. We call them true demarcated areas. Look at this. You have the same polyp as before, but this is zoomed in imaging. And in the center, there is no discernible structure to this demarcated area. So it's irregularly irregular or just irregular. And that would alert you to the fact that there's deeply invasive submucosal invasive cancer there. And indeed, this was SM3, so deep in the submucosa invasive disease. And it can be, of course, that there is no demarcated area because the whole polyp is a demarcated area. And in that case, it might look something like this, where the folds are drawn in. There's no real structure to the surface of the polyp. And this was also an invasive, deeply invasive cancer into the submucosa. So when you're looking at demarcated areas in polyps, remember regular, irregularly irregular here, or irregular with some structure. Remember these images, they're quite nice to remember. And remember that it nicely divides down the middle into low or high risk of cancer. Does this work in practice? Is it useful? Well, actually, in 730 assessments by relatively inexperienced endoscopists, it was 92% sensitive for the presence of cancer. So to summarize so far, blink impression is useful. First impression is useful with education. Demarcated area is useful and can spot overt or visible on the surface signs of cancer within polyps. But what about this polyp? This polyp does not have a demarcated area. Blink impression just draws your eye to this nodule, and maybe it's a little extra red. Sorry about this bleeding on here. This is nothing to do with the polyp, probably some manipulation. So you have a big nodule. It's blink negative. There's no demarcated area. So nothing on the surface, but there is still a risk of cancer here. And this concept has become more and more important. This polyp is in the rectum. It has a big nodule in it. It's granular in morphology and it's quite large. So what is the risk of cancer in that polyp? Well, Burgess, published in Gastroenterology 2018, this algorithm, numbers not important, for what constitutes cancer in a polyp where there is no demarcated area, and it is bigger in the rectosigmoid, non-granular, with a big nodule. And so what do we mean by that? We have to take a 2-second detour via the Paris classification. So 1S means a nodule, 2A, 1S means flat with a nodule, 2A means flat, and 2A plus C has a bite taken out of it, if you like. These are the ones with demarcated areas normally. So we're talking about these. And if we just have a look, the other thing we need to understand is granular versus non-granular. Granular are polyps that look like you're looking at them maybe through frosted glass, whereas non-granular, you can see that they don't have anything on the surface. So these ones are more like Rice Krispies, if you have Rice Krispies in your country in a bowl, and these are flat, shiny polyps. So remember this, if you remember nothing else about covert disease: large polyps in the rectum that are smooth and shiny with large nodules are potentially high risk for cancer buried under the surface. And if there is cancer, it's often buried under the nodule. So just as an aside about covert disease, what risk is high risk? Well, we have all sorts of risk calculation devices for this, but of course we are doctors, we're not just people doing polypectomy. And so a very important part of decision-making, we'll come back to this at the end of this talk, comes down to all these things about the patient and all these things that you might be doing separately. How good are we at this? Not very good. We're even in this cohort of educated people, we're about 65% at determining these characteristics. So that needs to be improved. So finally, I just want to talk to you about a structure for any colorectal polyp that you might find. This is it. You do your blink impression, you look for a demarcated area, you look for these, if your demarcated area does not exist, you look for these things that I've just told you about covert disease. And if it's low risk, maybe it's a flat thing, it's going to be low risk for cancer. If it has a big nodule, maybe you think it's high risk. But also if it has a demarcated area, you want to be looking for that irregularity of the demarcated area where it can tell you that you have cancer within the polyp. There is a nice calculator at geeks.com/SMI for that, where you plug in all the data, and at the end, you come out with a score for any particular polyp. So these are my final slides, final 3 slides. This is an image of a colorectal polyp from afar. There's some extra redness in the center. As we go closer, we can pretty much say there's a demarcated area there. And then you can very clearly see the normal on the edge, normal polyp, and then the center, which is much more disordered. And then we go to narrowband imaging. You can clearly see that this is a more irregular pattern than the outside, but it probably retains some structure. We might call it regularly irregular or JNET2B. And therefore, this is probably either high-grade dysplasia or a superficially invasive cancer. This one is your classic covert polyp, very big nodule in the rectum, and not much evidence of a demarcation zone on this polyp. And I'll give you a resource. We don't have time here to go and look at loads of these videos if you want to, which we've always scored up front for you, so you can figure out whether or not you think it's cancer and then see if you agree with us. And here's the link to try that. And this system can give you correct treatment in about 70% of patients in people who are not necessarily trained endoscopists. There's that summary again. So the take-home messages from this part: cancer prediction can be pretty good. Histopathology prediction can be pretty good with this method. There are some issues which we need to iron out. And so I think I have given you a simplified approach to endoscopic imaging the colon. I think I've given you a structure to stratify the risk of any detected colon polyp. Please go and look for loads more examples. And we're going to pause there and discuss this, and then potentially we're going to talk about the implications for patients if we get this wrong. So I'll stop screen sharing for a second, and we bring back in the panelists to have a discussion about that.
Thank you very much for this excellent lecture. And I think that, George, we're all going to go and practice our detection and characterization techniques now, us too.
Yeah. Can I ask a great talk, David? There's all the rage, as we know, about enhanced imaging techniques, NBI, and AI. You haven't said much about them. Now, clearly, it may be another talk, of course, but is there a reason for that? Do you think that in the majority of cases, majority of colonoscopies and polyp characterization that we do, that good white light is giving us the vast majority of answers?
I do think that good white light can give you the answer as to whether it's a deeply invasive polyp or not. But I think I mentioned NBI in terms of the structure of any demarcated zone you might find. I really do think it's very important that you get acquainted with the virtual chromendoscopy function of your endoscope, whatever endoscope brand is. And I do think that you should use that function, which of course highlights the blood vessels, to look at the blood vessels around the crypts and see if those crypts are completely regular, if they're slightly disordered, or if they're completely disordered. And that can really put you into three big categories: totally regular, totally benign. In the regularly irregular section, maybe it's high-grade dysplasia, maybe it's early cancer. And in the totally disordered, probably it's deeply invasive cancer. So I do really think that can be very helpful. AI, not ready for prime time, in my opinion. It's certainly something that can help you decide if something is a polyp or not. But as I'm aware, in the Western world right now, not something that can help you determine whether it's cancer or not.
Okay, thank you.
And there's any use for a non-digital chromendoscopy, so indigo carmine, crystal violet?
Definitely. And those of us who are doing interventional endoscopy and maybe tissue resection are using it a lot. But of course, when you're in the middle of an endoscopy list, it is much easier to just flick the light, right, to NBI or to BLI or to iScan, rather than getting dye out. And of course, you may also not be familiar with the different types of dye unless you've done a long endoscopy fellowship and the different properties, and maybe the nurse doesn't know the concentration, et cetera, et cetera. So I do think that virtual chromendoscopy offers pretty much the same information. Japanese would certainly disagree with that statement. But my view, pretty much the same information at much less resource, much less time, and much less, interruption of your diagnostic colonoscopy list.
So as non-experts, at least I'm very aware that I have to take good pictures, have a very good image, try to use the digital chromendoscopy as the best I can. What about biopsies? I know that biopsies is a no-no. Is it still a no-no? Can we make a small biopsy in some part that seems a bit suspicious?
I think that's a great question, Marianna. I think that, of course, the most important thing to say is don't be afraid of taking biopsies. And if you don't have access to a local MDT with a tertiary endoscopist, then maybe it's something you really have to do. If you're going to take a biopsy, don't take that, snare biopsy, which involves taking a huge part of the polyp off, because that's going to make it more difficult to endoscopically resect. And apply this structure that I've just given you and focus your biopsy on the most abnormal looking area of the polyp. And by which I mean the most disordered structured area of the polyp, because that's what's going to give you the most information. Taking a biopsy of a big nodule, even though it might be attractive, is not going to give you any information because the problem is under the nodule.
Can I add something to that? I think, it's a beautiful talk, fantastic slides, David. And I think for those who are not familiar with all the classifications, you make a really good point, which is don't worry necessarily about the names of all of these, just describe what you're seeing, but also understand that actually to examine a lesion, even a relatively small, say 2 centimeter lesion, like you showed, it takes a few minutes. Right. So yes, have your blink and first impression, but actually to clean it and wash it, gently, not too vigorously, you know, to take the time to switch through, whether it's NBI or, you know, the other options, put a bit of dye down, clean it, wash it, look at, you know, deflate, inflate. It takes, I don't know whether you've got any data on the information, but the time you, sorry, if you've got any data on the time we should spend, but if you spend a good, you know, maybe 2 minutes examining a lesion, you'll be surprised at what you see when you really start looking, I think.
I think that's absolutely right. And I do think you can gain a lot of information in your first impression, but there is real meat in spending more time, making sure it's clean, making sure you don't make it bleed before you get in there with your water jet, for example, being too strong. All of these things, there's not stool, etc. Very important. I totally agree with that.
And the point you make about a single biopsy or 2 biopsies, again, if you think there's a focus of cancer within a lesion, then definitely be really clear to take the first biopsy, not in the most accessible bit, but in the most abnormal bit. Because once it starts to bleed, which by definition, the cancerous bit will bleed, if it's a small lesion, it's game over, and the rest of your biopsies will all be the TVA, and you'll miss the fact that there was a bit, you were right, there was a bit of cancer in the middle. But if you don't biopsy that first, then you may well lose the opportunity to make the correct diagnosis. That's
very, very important. And I think people, I don't know, you've almost certainly all seen this, but people also biopsy huge cancers, right? And get tuberculous adenoma with high-grade dysplasia out of it. And why is that? Because they're just biopsying the very edge, which is polyps will turn into cancer, right? We know that. So they're just biopsying the polypoid part of the thing. So it's a very important point.
Okay, brilliant. Great discussion. We're now moving on to the last presentation of the evening. And David, it's back to you. And actually, in many ways, bringing the threads together of both the talks so far, and that is, you know, the implications of getting things wrong, which happens in all of our practices. But we'd like to hear your views about, well, you know, the problems related to that, and by inference, you know, how to minimize that risk.
Thank you very much. You see the screen again, right? So the reason for talking about all of this, and it very much also pertains to colonoscopy, because as Manmeet very much pointed out, to get to polyp detection and characterization, you must be able to do a colonoscopy and get to the caecum. The importance of this is that out there in the wide world, as I think I showed at the start of my other talk, there is unexplained, maybe, but also unacceptable variation in outcomes that are for patients. And this is potentially that patients get complications that maybe they didn't need to get, both immediate and delayed. There are lots of surgeries going on for benign polyps out there. We know that from huge data sets. Post-colonoscopy colorectal cancer, so cancer happening after a normal colonoscopy, can occur because of incomplete polypectomy. Incomplete resection and then recurrence leads patients to have lots of procedures or even surgery when they potentially only needed a single procedure and then normal standard surveillance. And in general, observation of clinical practice indicates this to us. This is an image of a patient who had to be re-endoscoped 2 weeks after a polypectomy. And you can see here a very clear ulcer from the polypectomy and a very clear residual piece of polyp on the edge of here. Here you can see a mature endoscopic resection scar with a large recurrent polyp within the center. And here you can see the other flip side of the coin, a person who has started a polypectomy and is unable to finish, and this patient ended up having to have interventional radiology procedure to stop bleeding after this procedure. So I'm just going to talk a little bit about how it regards to polyps. It's going to take 2 or 3 minutes, and then I will invite the rest of the faculty for their comments on this and how it relates to everything else. So if we're thinking about the cancer risk of a polyp, I've just told you about all that. We can consider it low or high. If we think it's low, then piecemeal EMR is standard of care because it's safe, effective, and not dangerous. High-risk polyps need to be removed in one piece, either by surgery or en bloc endoscopic resection. The healthcare resource use and the risk to the patient is much greater with these 2 techniques than this technique. So if you get the cancer risk assessment wrong, and that's why I focus completely on cancer risk, then you subject the patient to more risk and more cost, and your healthcare system to more cost by getting it wrong. How can we get it right? Well, endoscopic imaging is key. Why? Because endoscopic imaging can be performed in real time. It can also assess, as Siwan was pointing out, the whole polyp if you spend time and if you make the effort to clean and fully assess the polyp. The downsides that we already mentioned are it requires expertise. I hope maybe by this and lots of examples that expertise can be gained by anyone, and it's mainly seen as too complex for the majority of people to do. So what are the consequences of getting it wrong? Well, they are, if you assess the cancer risk of a polyp as low, but you do en bloc endoscopic resection or surgery, so the polyp is actually low risk, but you choose a high risk technique, that patient is subjected to excess risk in terms of the risk of surgery, which can be mortality. People will be stunned to know the risk of a right hemicolectomy. The risk of mortality is not zero. The risk of morbidity is nowhere near zero. And we see that as a standard surgical procedure that's relatively safe. En bloc resection endoscopically takes more time, more healthcare resource, and where you're not in a propofol environment can be difficult or impossible. And for the patient who has a high risk polyp for cancer, but you perform piecemeal endoscopic resection because your decision-making is incorrect, that patient probably has delay to the definitive treatment they require. The resection you do is unnecessary, therefore any risk from that resection is unnecessary for the patient, and they lose the chance to have had an endoscopic cure and not have to proceed to surgery. So the consequences of getting it wrong really are a negative patient experience, a cost to the environment, and by that I mean more procedures than the patient needs, more healthcare spend, more resource use, more carbon use than is required, and a financial cost to the healthcare system, not to mention the risks that I've just talked about to the patient. So that's a little deconstruction of it for polypectomy. It applies, I think, to colonoscopy technique and small polypectomy as well. But I'll be interested to hear the comments of the rest of the panel in the last few minutes that we have on that, and on how they see it, and look at any questions that are in the chat.
David, can I just ask, should interventional colonoscopy be in the hands of a smaller percentage of colonoscopists? I mean, clearly the focus on this webinar this evening, quite rightly, is doing the basics right, and you and Manmeet have beautifully described how to do that in terms of the technical aspects of colonoscopy and lesion recognition. But it strikes me that in some ways an elephant in the room of colonoscopy practice right across Europe is, should everybody be having a go at most things? And no. If not, should there be specific polyp criteria, particular scenarios in which we should say, no, this case should go to David Tate and his high-end interventionalists, or these cases it is entirely reasonable to stay within more general colonoscopy practice because the experts can't do everything?
It's a really great question. It deserves a whole webinar, but I'll just say you've kicked the ball really high up in the air for me to say that we are just about to publish at ESGE Days the EMR, the curriculum for EMR training in Europe. And that document, which is its current form 100 pages long, I hope it won't be once it's typeset, it is a great window into the answer to that question. So yes, I do think that cases should be focused on intervention endoscopists where they are more complex than the average. How do you define that? Via, I think, the SMSA classification is a great way to start. As Siwan was one of the authors on the original paper, we definitely should get her to comment on that. And then based upon a person's competency, really, and how do you define that? And I think we've tried to start the conversation about people's competency in polypectomy in that document. And I think it's via a validated scoring system, doing a fellowship of a defined period of time, or a period of training of a defined amount of time, and being someone who is doing that sort of thing all the time. And George, I know that you're very much on the ERCP side of that, but I do think the messages are the same for polypectomy as they are for ERCP, right?
Yeah, I agree.
I assume we don't hear you, or I don't.
Sorry, one of the reasons we developed the SMSA scoring system. So for those of you who don't know, it's I think it was published in Frontline, and there's been various follow-up papers validating it with yourself and Mike Burke, I think, David. We're quoting ourselves, which is never good form. But anyway, is that it stands for size, site, morphology, and access. So it grew out of the observation that you can have a complex polyp, a difficult polyp to remove, even if it's quite small, if it's in a difficult position, say associated with the appendix orifice or only visible in rectal retroflexion and so on. And it grew out of the bowel cancer screening program in the UK, where actually we discovered at the beginning of the program, it's now very mature, that we had very good diagnostic endoscopists in the program, but they ran into problems with all of the things that we're talking about now. And if you use a scoring system like that, either within your department or within a polyp meeting, if you have a polyp meeting, or even if you send the images off to a colleague and you describe those four things, the size, the morphology, the site of the polyp, and the access onto it, even those four things will give you a lot of information that Mike and Dave demonstrated correlate with complications and poor outcomes. And that's the important bit. It's not just that, oh, it's a big polyp, you know, I don't want to remove it. It's that it correlates with a poorer outcome for the patient. And that's where the two things join. It doesn't go into the whole visualization that David was talking about. That's added on. It's kind of a detailed blink, if you like. But if you get used to using all of these descriptive tools, and you will validate yourself in terms of what you are capable and shouldn't be taking on. It's a learning curve.
I think it's really common sense, isn't it? I mean, it's one of the things that's always struck me about the SMSA scores. It's relatively common sense when you think about it. But even amongst experts, it predicts complications, it predicts recurrence. So it's a great tool, I think.
Okay. Manmeet, did you want to give any final points before? We can't see you, Manmeet, but before we finish up, there you go. Did you have any points you wanted to raise?
I think just be humble, really. Colonoscopy is difficult for a reason. We all struggle at whatever stage we are. So this thing about being an expert colonoscopist, doesn't mean you're always going to get it right. So be humble, reassess, put the patient first, be safe, and go back and sort of think again. Take a team approach. I always read the cue from the room. And if my nurse is giving me a nudge, I know that there's something adrift. But I think, do the basics well if you want to be an expert.
Okay, that you've almost summed up for me, Manmeet. That's a great quote, I think. And I think, every week I have to humble myself when I come across a difficult colonoscopy. But that's what makes colonoscopy so interesting, right? Is it's never, ever the same, even the same patient with the same scope and the same endoscopist. It's different each time you do it. So for me, I think I've got 3 or 4 take-home messages, and they are to think about the indication for your colonoscopy and choose your kit accordingly. I'm not going to rehash it all, but that's everything from the scope you use to whether you use water and add an endocuff and so on. If something's not working, physically stop and rethink through the algorithm. What else is there? Ask the people in the room around you. And when you come across a lesion, small or large, by all means, get your gut response, your blink response, but then take the time to examine it, because even small lesions, we had a 6mm cancer recently on our bowel cancer screening program, and it's only if you use the algorithms that David has so beautifully described that you will pick that up and not make the wrong decision for a patient. So get what I talk about, a bird's eye view, and then hone in. I try and avoid the use of the word zoom, because people think I'm talking about a zoom scope. You don't need a zoom scope, but get a bird's eye view and then go in for the detail and use these tools to describe the lesions that you see. Marianna,
that's
you, or was it George?
Really sums it up very, very nicely. And well, from my side as a non-expert, I would say to learn these tips and tricks to give the best description possible of the polyp in your reports. Take tons of good pictures for the bird's view and the detail, and don't do anything crazy.
Can agree with that.
So, George, you have anything else to say before we remind everybody how fantastic ECG is? And we have loads of stuff going on the platform. So if you're members already, thanks. And it's time to renew. Don't remember, if you're not members, please become a member. You can watch all these webinars and much, much more. And of course, the big thing that's coming up is Dublin. So we hope that we can all meet you there for lots of sessions on polyps and more. And of course, we continue our webinars. The next one is going to be after the days on a Wednesday, as usual, May 3rd. So we're going to have a surprise webinar, but please keep joining us on Wednesday evenings. And to wrap up, of course, a big thanks to the ECG Governing Board and, of course, our fantastic webinar team, David and Gabby. And, of course, a great thanks to this fantastic panel and my the two great speakers and my co-moderators. So have a very nice evening, everybody, and we'll see you off in Dublin.
See you in Dublin.
Thanks. Bye.
Bye.
Bye.